Okay, let's move on to our questions. We have some questions here. So here's a question that maybe Pat, you could start off. It's from Representative Jill Billings. If you could drill down into the infant mortality numbers, have we had any improvement in the last several years or slowed the decline?
Well, again, it's a great question. Sometimes following your rank, um, the Badger basketball team can be dropping in ranking, but it's just because other teams are getting better. We're in a tough Big Ten conference this year. So Wisconsin's infant mortality rate overall has been declining, but it hasn't been declining as rapidly as other states. So that's an important. Many people, including myself, sort of quickly, when we see our drop in rank, we think that things are getting worse. Smoking is another good example. Smoking rates have declined slowly, but not as quickly in Wisconsin as in other states. So, but what is important is to look at the subgroups for infant mortality, not just by community, but by race and mother's education. And so it's quite a complicated answer. It depends. It depends on where you live. It depends on the race of the mother and their social and economic circumstances. There's a number of great resources, both at DHS and in our own Wisconsin Medical Journal, where people have sort of teased out the complexity of what seems to be a pretty simple number, just the rate of infants who survived their first year. But really, I would say the importance is in the details, to dig down, to look at those circumstances where we have not achieved the outcomes that we want. So it's not exactly an answer to your question. Things have been getting better in general, overall, but our disparities have not been getting better. And when you look at the infant mortality rate in Milwaukee in particular, that's really driving our overall challenges.
Great, thank you, Dr. Remington. I have a question that perhaps Peter, if you want to start on this one, it's from Senator Janet Bewley. She suggests to colleagues that access to the internet is an essential component of quality of life. Can a direct link to health outcomes be a part of my argument?
I would say that any form of education is going to be good on face value, but I haven't seen any evidence for or against that, so I really don't know. My guess is probably, but I'm really not sure.
All right. I have a question from Justin B., who is a legislative staffer. This one might be for you as well, Peter. We've seen that there are multipliers for spending on education. Spend X amount of dollars on education, get X amount of dollars in societal benefit. Is there a similar multiplier for public health spending?
Yes. Yes, certainly. I think it is a very challenging question because, as I sort of pointed out during the talk, education, you can spend it on pre-K, you could spend it on reduced classroom sizes, you could increase teacher salaries, but you're not going to get the same value out of all of those kinds of investments. And the same is true for other multipliers. So, it's a very broad question. It really depends upon where specifically you channel your money. And I think that's the broader policy point. But yes, there is a very similar multiplier, but it depends upon the specific program you're looking at.
Did anyone else have a comment on that? Okay, great. We have a question. This actually might go to all of you, but maybe Arjumand or Peter, you could take this one first. How, in looking at all of these statistics and trends, how does the stress of a single parent household compare to the stress of a two-parent household?
So we have direct data from randomized controlled trials. You want me to talk about those first, Arjumand? Or?
Yeah, please go ahead, Peter.
Sure. So from randomized controlled trials, you see that families with one parent households tend to have a lot higher stress and a lot higher financial stressors than two-parent households, simply because you've got twice as much income and you've got more child support, et cetera, in a two-family household. So we find that money directed towards single-parent households tends to have much bigger health impacts because it helps supplement the income from the partner who isn't there, who might be a provider as well. Arjumand, do you want to follow up?
The only thing I can really think to add is that if you look at the child poverty rates, those are really an expression of the poverty of single women. So single parent households are by and large households that are headed by low income, particularly single women. And so the stress of being low income is both an issue of being a single parent household, but that's really another way to say it's the stress of being a low income woman who's a parent.
Great, thank you. One more question from Angela. What is the #1 low-hanging fruit of a state policy solution to address the root causes of health disparities? And Arjumand, you want to take that one first?
Sure. So I'm going to answer this as the scientifically low-hanging fruit, and that is to say what I perceive to be the avenue that has the most evidentiary support. And if you think about it, it's essentially how to provide more economic resources for low-income families. And so that is both income and, by the way, wealth. So we tend to focus a lot on income, but really what's driving income and the ability to produce income is wealth, and particularly intergenerational wealth transfers. So the reason that higher income people are able to go to school, not have debt, get down payments for homes early in life, and so on, is because they get transfers from their parents and grandparents in previous generations. And so that cycle of economic inequality perpetuates because people start off life on different footings. And so to me, the most low-hanging fruit would be to do something about the wealth differential, which is then creating an income differential.
Yeah, and just to follow that up, I would say that if I were to pick an intervention, it would probably be pre-K, early intervention programs like Nurse-Family Partnership that have really proven to work. And I think one thing that's very prescient is that in Nordic countries where education is free throughout the whole the span educational years through college and everything, economic mobility is really high. So people who are born into poor families are almost as likely to become wealthy as people born into wealthy families in those countries. But in the US, economic mobility is really low. So if you're born into a poor family, you're stuck there. And one way of overcoming that barrier to increasing your wealth is through education.
Pat, did you have anything to say?
Well, I just couldn't agree more. This is what we talk about in public health is moving upstream, from the bedside to the community to those factors that influence children's lives. And that's what the Family Impact Seminar is all about. If you can intervene early through not just evidence-based educational interventions, early childhood education, but cost saving. We in public health talk about these as no-brainers. Why wouldn't we as society, as policymakers, invest in things that improve outcomes and save money? And I think Peter's research is, just so important to put that really into practice, to look at those investments that achieve the outcomes we want, and either at a good value for society or occasionally cost savings. And I think early childhood education is a great example of that.
Well, we are out of time. I want to apologize that we could not get to everybody's wonderful questions. I think we could keep going for hours and hours. Such a good discussion.